And welcome to our live stream for Duke laser disc repair surgery on the cervical spine or neck. Our patient travels to us from Indiana. He is here with his mother and aunt, and he's a young man who's suffering from herniated discs. He has 2 herniated discs, C5-C6, C6-C7, and they are not just causing neck pain, but also intermittent headaches, pain radiating down into his right shoulder and his arm. He has numbness, tingling, and weakness in the right arm. So he found Duke Spine Institute, and other surgeons of the spine would recommend removing the discs and replacing them with metal and plastic. At Duke Spine Institute, we don't remove discs, we repair them. Repairing discs is the new thing. It is a better surgery, it's safer, and there's no need to take your natural disc out. If it's working fine, we just have to fix the herniation. So the first thing I'm going to do is place my needle. It's a little tight. All right, 2, 3, 4, 5, 6, 7. So I want to be a little bit lower. I'm going to try to start at 6, 7. How much time do we need?
Oh, I should be fine now.
It feels better already. Shot. All right, so I'm going to move south. Shot. Everyone agrees that's 6, 7, 2, 3, 4, 5, 6, 7, yes?
Yes.
All right, shot. I'm going to go in. Shot. Shot. AP quick. As I place the first needle, I'm going to check the positioning. Yep, perfect. Front, back, side to side. Shot. All right, we are entering the disc. This is number 6, 7. Shot. Now, I was talking to his family in the waiting room, and we were talking about the surgery. He's got really great family, by the way. I was telling them we've been doing this now for 19 years almost. 2, 3, 4, 5. Everyone agree we're at 6, 7. In the 19 years we've done this surgery, we've never had a single complication. That's a very safe surgery that's never had a complication in 19 years. Give me a little bit of shoulder action. And shot. All right, we're going to see the tear. There it is. Look at the size of that tear. It's massive. That's all the black dye leaking out the back of the disc. It should be staying in the middle. Perfect. Give me an AP view. We're going to get another view from the front, and it'll show the dye leaking out the sides. There it is. Look at that. Show the dye right there, Jordan. We're going to show you guys how the dye is leaking out through a tear on both sides, but worse on the right. And guess, see that black thing there? No, go to the right. Go to the other side. Patient's right. Yes, that's the tear. Look at the little line. That's the tear. Dye is leaking out. That's why you see it. And you see that black thing right there? That is the nerve root right behind the disc, right where the herniation tears out in the back of the disc, right where the nerve root is. And the dye is now wrapping around the nerve root. All right, shot. Henry, any questions?
At this moment, no current questions.
All right, Henry, why don't we show the audience, you know, there are about 30 different things that cause neck pain, but the herniated discs, which are also called bulging disc, ruptured disc, extruded disc, protruded disc, degenerated disc, those disc injuries are the #1 cause of neck pain. They account for 85% of neck pains as the primary cause. Let's show the audience those 30 causes of neck pain while we get into this disc and start fixing it. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3, next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Welcome back. So you can see from the video there are 30 different things that cause neck pain. They include discs, facet joints, fractures, and then of course the rare tumors and infections. Now, these 30 causes of neck pain, the most common by far is a disc injury, which is what we're treating in this young man. And he is having horrible neck pain. Shot. As I advance the tube into the disc, I have to watch to make sure the dilator doesn't move backwards more, make sure that things stay where they are. We are now entering the tear where the herniation is, at the back of the disc. There we go. We are now at the back of the disc. This is number 6-7. Jordan, let's count for the audience. See the arrow?
Yes, we do.
Up to 2, 3, 4, 5, 6, 7. We are at C6-7. We are inside the disc, and the tip of this tube that I'm using, it's a 4 millimeter incision. Let's get the light on here. Check this. No, yeah. Check it out, guys. This is really cool. So where other spine surgeons, every other spine surgeon in the world is taking your disc out and putting a cage made out of plastic or metal or an artificial disc. You don't want that junk in your neck. We fix your disc, we repair your disc. Other surgeons remove your disc, replace it with metal. We're repairing discs. Why get rid of your disc when it's perfectly good? The answer is the other surgeons don't know how to do what we do. If they did, they would love to do it, but they don't. Look at the incision, 4 millimeters. Okay, he's going to go home in an hour after his surgery, and his symptoms should be gone. He may have a little numbness, a little discomfort from the surgery overnight, but then that goes away. Any questions from our audience?
At this moment, no current questions. So in the meantime, why don't we show the audience of how it is a herniated disc causes neck pain?
Of course, I think it's a great idea.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Welcome back. You can see that the way discs become painful after injury is there's a tear in the back wall. That's what you're seeing right here, folks. See the white? See the
Yes, we do.
white? That white is ripped open, and the blue stuff is the herniation getting pushed out. That's herniation blue, annular tear white, and guess what the pink stuff is? Inflammation. That's what we're here to clean up. boy. Nikki, if the laser's broken, the laser's broken. If it's a technical error by the person using it, then it's a technical error. Let me know when I can go. That would be a technical error by you. All right? Don't blame the laser.
Since there are no current questions, why don't we show the audience of how it is the Duke laser disc repair cures neck pain?
Of course.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debreeds the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Okay, welcome back. You can see how we repair the tear and the herniation using a laser. I want to show you this. You guys see the laser at 12 o'clock?
Yes, we do.
All right, that's a glass fiber. It's 0.5 millimeters. It's 0.5 millimeter wide. That's how small it is. But look at that right there. That is a herniation, that white thing or bluish thing. That's the nucleus pulposus. And look how it's going out through the tear right there, pushing on the spinal cord. That is a huge herniation. And I am zapping it away, just the herniation. We are only removing the herniation right now. We are not removing the disc. See, other surgeons are going to take your disc out and they're going to get rid of it. Then you won't have a disc anymore. And then they use that as an excuse to put metal in your neck, when the real thing they should be doing is going out and learning how to do this surgery so they can give their patients better treatment. This patient had to travel from Indiana here to Florida to Duke Spine because there's nobody in Indiana that does this. They're just doing the old type of surgery with fusion and artificial disc, which is dangerous, both of them. So he didn't want that kind of surgery. He knew better. There's a piece of herniation. And he said, I'm going to go to Duke Spine and get the laser done and have laser spine surgery. All right, Henry. Any comments or questions?
Yes, we have a comment coming from a past patient from YouTube saying, what an amazing team. A year ago, I had T8, T9 done by Dr. Duke, and he completely removed my pain in that area.
Oh,
I even was able to have the spinal cord stimulator removed as I didn't need it anymore.
May God bless you, and I hope you stay pain-free the rest of your life. I hope everybody gets pain-free. There's nothing in life that would make me happier than to cure everyone's pain. I'm so happy you're doing well. Thank you for sharing your story. We just did 2 thoracic DLDRs last week, one on Tuesday, one on Thursday. By the way, look here. That is the herniation. You can see now that I'm removing it, you're starting to see a little bit of herniation left still. I'm going to get that too. But the beauty of this surgery is that we don't remove your disc, so you don't need a replacement of your disc. We also can see exactly the herniation, and I can remove it, literally taking away 0.05 millimeters at a time. That's how precise this surgery is. The laser is far more precise than any other treatment in the world. Other surgeons that do disc removal and replacement, which I used to do, by the way, they can only see about 0.5 millimeter. They can only see about 5 millimeters. 5 millimeters. We see 0.05. We see 100 times more precise using the endoscope than they do. They cannot see any of this stuff down here. When those surgeons are operating on you and they're taking your disc out in your neck, They're literally taking a metal instrument called a curette and a kerosene rongeur, and they are scraping around back here, hoping to get some of this herniation out. But they could actually do more damage than good because they're blind. They're not seeing what they're doing. We see exactly what we're doing. So when people talk about laser being dangerous, those are doctors that don't do laser. They just want to scare you away from getting a laser procedure. It is wrong of them to do that. It's unethical. They don't know anything about laser, and yet they're trying to scare people out of laser because they're losing business. That's what it comes down to. For me, I used to be a fusion surgeon, an artificial disc surgeon, a disc replacement. I did 1,000 of those surgeries in my career. 1,000. That's a lot. And when I started doing these lasers and I realized there were better results with the laser than with fusions and artificial discs, I stopped doing the fusions and artificial discs because I was doing harm to the patients. I was baking a big cut on their neck. I was causing scar tissue. I was putting a metal plate. I was fusing the bones so they don't move anymore. They were losing their movement. They were getting adjacent segment disease, all the kind of things that other surgeons get. So with this surgery, we never get adjacent segment disease. We don't lose the movement because we're not fusing and we're not putting anything in your neck. Look at that. That's all herniation there that I've zapped away. And now you can start to see more normal spaces. Questions?
Yes, we have a question coming from, forgive me if I mispronounced the name, Marwan on YouTube.
Marwan, I remember that name.
Yeah.
Wasn't there a Marwan in the Jungle Book or something?
That
Or
was
is that something
That
else?
was Mowgli.
Mowgli. I apologize.
I knew what you meant.
Marwan. That name is familiar. Maybe
It does
it's a
sound
patient.
familiar, yes.
Maybe it's a patient.
Coming from YouTube asking what size of a herniated disc could be suitable for this procedure.
Thank you, Marwan. All herniated discs can be suitable for this procedure. All herniated discs. It doesn't matter how big it is. We can remove it. Look at this. We're removing the disc herniation from the inside out. Just past this area is the spinal cord and the nerves. So we're literally removing it from the inside out. It's the safest way to do it in the world. There's nothing safer. Great question, Marwan.
Next, we have a comment coming from Fronathan on YouTube. Jonathan, but with an FR.
I
Fronathan.
like it. Fronathan.
Saying that they just got their passport paid for yesterday. It's coming in February, and they're coming to see you, Dr. Duke.
Fronathan, I look forward to fixing you. Thank you. I would love to know where you're coming from.
I will let you know once they reply. At this moment, no current questions.
All right. So the beauty of what we're doing, you see all the stuff that I've lasered away, that's all herniation. None of it is normal. None. So by doing this surgery, we're not taking any good normal bone or ligaments out. We're just taking the herniation out. So this is such a nice surgery because it preserves the normal structures of your spine. It doesn't remove normal stuff like other surgeons do. And the only reason why we can do this is because we're doing it arthroscopically. This technique of the arthroscope, the tube and the endoscope here, was developed by the South Koreans. I talk about this a lot. Dr. Sang-Ho Lee and his assistant, Dr. Gun Choi, who's also a neurosurgeon. I was trained by both of them, met them and trained with them overseas many years ago. He probably doesn't even know my name, but that was back in, what is 18 and a half years ago? 19 years ago now, basically. Actually, it was 19 years ago I was trained to do this by them. That was that 2006? So it was 2005? Christmas time, 2005. Yep. I had heard about it. I didn't believe it. I didn't believe it could be done. I had to see it with my own eyes. And see it I did. By the way, that is a tear in the posterior ligament. And I'm going to see if there's any herniation back there. What's behind this is the spinal cord. All right, but there's a little gap right there, which tells me there could be some herniation stuck in there. And I do not want to leave herniation. But look at this. I'm peeling this away at 0.05 millimeters per pulse. That is as precise as it gets, folks. So yeah, this young man did not want to have a fusion. He did not want to have a disc replacement. He did not want to have conventional spine surgery. He knew there was something better. He found us, and he's here with his mom. And this will be his Christmas gift. I hope that he gets out of pain. That's a piece of herniation right there. So I'm going to have to look around a little bit. There's a piece of herniation coming out. Any questions?
Yes, we have a question coming from Fronathan once more on YouTube.
Okay.
Saying, I've got a question. My doctors are negligent. They will not give me an MRI, and 6 years later, they still haven't done a thoracic MRI. I'm coming from Vancouver, Canada. I need an MRI, willing to travel, looking to have my spine looked at by someone that knows actually what they are doing. Over time, with all the sharp pains and swelling in different areas of the spine, is it possible I have been injured further, especially as movement disorder has developed?
Yes. Yes, Fronathan, but don't worry. We can help you. We can fix it, and we can get you to where you have normal movement eventually once you heal up, and you have normal nerve function, hopefully, as long as you're not paralyzed when you come here. But before you come here, I don't mean when you come here. I mean, as long as your neurological deficit doesn't get to the point of, paralysis before you get here, we can fix a lot at Duke Spine. We just got to get the pressure off the nerves, like this patient, his nerves were getting crushed here, and spinal cord was getting crushed, and we need to get rid of your pain source, which is the back of the disc, likely. I mean, if you're having a disc problem, that is, which I suspect you are. As far as the MRI goes, typically we can do an MRI at Duke Spine. We have an MRI scanner here, but it's small, so it's limited in terms of the body habitus. Big people cannot fit in it. So, but we do have an MRI scanner down the street that they could do the MRI. They have very reasonable rates. Their charge is around $250 for an MRI. That's US dollars. You won't find it that cheap anywhere else. So we try to give people the tests that we can as inexpensive as possible so they can get answers. And then we try to do the treatments as inexpensive as possible as well. All right, just about done with this one. I do have to open this area up more to make sure there's not a herniation behind it, because I don't want to accidentally leave something here that we should have taken out while we were here. These are all scarred fibers of what's called the posterior longitudinal ligament. That's the neural foramen on the right. That's where the biggest part of the herniation was. I do have to look here, and I've got to look in one more spot as well. This is all still some herniation. I got to get rid of this. I got about 5 minutes on this disc. I think the 6-7 was the worst, or 5-6 was the worst. Guys? For some reason I thought 5-6 was the worst. But this 6-7 is bad. It's worse than I thought. Maybe it got worse since he got the MRI. What's worse there on that MRI? Jordan? So 5-6 is worse, right? Wow, so this herniation has gotten worse since he got his MRI. So he had his MRI done. When is this MRI done? So this was just done in November, like 2 months ago. 2 months ago, basically. And I can tell you right now, this has gotten worse since I did the MRI review. It did not look this bad. It was a lot worse. Interesting. That's one of the advantages of endoscopic surgery, is you can actually see if things have gotten worse. And it has. That said, it's still fine. We're going to fix it for him. It doesn't matter if it got worse. But it's kind of like you're fighting a war. I love using military analogies. But you're fighting a war. Your intel says the enemy is over the hill. But it turns out the enemy is not just over the hill. They're actually over 3 hills, 3 different hills, and they're over all of them. So there's more enemy than you thought. You still have to fight the war, but it's be nice to know that sort of stuff ahead of time. Unfortunately, I can't get that in everybody. All right, so here What's happened is he's blown out a big piece of herniation right here. You guys see that? And it's there, and I got most of it. That's kind of no man's land. That's where the spinal cord is. We don't want to get too carried away. I don't want to be too aggressive down there. I mean, Jordan, before on the MRI, it looked like a contained herniation, right? Wait, I got to go this way. Sorry, Luis, I apologize. Wait, okay, that's that. All right, so I do have to go that way. Apologize. Let's go take a look. Huh? It was contained, and now it's gone through. All right, we're almost done here. So the good news is, even though it's worse, we're almost done.
We have another question
Sure.
coming from Fronathan once more on YouTube, saying, last question, what are the typical wait times to get in to see you? I'm looking to be in before the end of next July.
Yeah, I mean, Fronathan, if you came to my office and showed up at the door, as long as I'm here, we're going to see you. We don't turn people away. I know a lot of doctors make people wait, turn them away. I think that's cruel and unusual punishment. Our office will see you as soon as you get here. We want to help people get better. We don't believe in making people wait and suffer. So as long as I'm here, I'll see you, even if you were to show up that same day. We prefer you make an appointment, but you know, anybody that's suffering so much can just show up and I'll see them. Okay? And we don't even charge usually for the first office appointment. We do it for free because we don't want people to have to worry about money to come see me. We want them to just get here and be seen and hopefully make a diagnosis, and then we can tell you what's wrong and if we can fix it. We're not done. I just got a big herniation I got to grab out. So my point is, unlike other doctors that push you off because they don't really want to see you and help you, we actually want to help you. I just pulled out a piece of herniation. It's just one of several, but I wanted to show it to you. You guys see this, Henry?
Yes, we do.
There's a couple of them right there. So just to give you an idea about the size. Thank you, Luis. These herniations look big on the scope, but they're really not that big. But the problem is there's lots of them, right? So a herniation is actually like 30 pieces about that big. And when you add them all up, it's like having a bag of marbles, you know? One marble in the bag isn't so bad, but when you have 30 marbles in that bag gets pretty heavy, pretty dense, pretty full. So the bag would be the herniation. The marbles would be pieces of herniation that make up the big herniation. Hope that makes sense. All right, we're pretty much done with this level. I'm going to be moving up to 5-6 next. Remember, 5-6 was the really bad one. We almost, I told him he should do this level too, and I'm glad he did because it got worse. I didn't know it got worse. But now that I'm in here looking around, it's definitely worse. All right, any more questions?
No current questions, so we do have a comment coming from Fronathan once more on YouTube saying, thank you, that's all I needed to know. As soon as my passport comes in, I'll be calling the office.
Yeah, wonderful. All right, I look forward to seeing you and hopefully fixing your problem, whatever it is. Someday I would love to have an office over in Europe, Asia, all over the world, a Duke Spine Institute. But that takes money. Money I don't have. All right. Looking good. Maybe a little bit right here. Like the never-ending herniation. That's it. Let's float it out. So what I'm doing is once I get those pieces of herniation in the tube, I kind of raise the tube up and float them out of the body. That's one way of getting rid of herniations. If they're loose. If they're not loose, then you have to zap them with a laser like this, or you got to grab them and pull them out. Okay. Any other questions?
We have a comment from BJ on YouTube
Sure.
saying sending MRI today for review. Looking forward to speaking with you. It is a question. How long does it take from review to the actual surgery? Thank you, BJ from Arkansas.
Hey, BJ. So if you do the review with me today, you could come and have surgery tomorrow. We'll fit you in. I really believe in helping people get well as quick as possible. I am going to be out of town for a week, so I won't be available, during Christmas. That's my one vacation with my family, my kids, my wife, and but otherwise, I love being here helping people get better. All right, my gosh, there's so many herniations here, guys. This is the last one, I think. Hopefully. I keep saying that and then I find more. But I just want to make sure we get as many as we can out. Remember, we're not going to get 100%. There it is right there. Henry, you see that?
Yes, we do.
You can kind of, it's kind of hard on that background, but.
Yeah, we can see right there.
But you can see that.
Perfect,
now that's
yes.
going to be about, that's a good size one. That's probably the biggest one. It's about 5 millimeters. It's like a little asteroid. And people always think I got a herniation. It's actually about 30 herniations. They make up that herniation appearance on an MRI. I've never found just one piece of herniation, ever. And I've removed, how many thousands of herniations. All right, we're done. We're done. That's it. We're going to go on to the next disc next. What is this? Now, when I learned to do endoscopic surgery from the South Koreans, Dr. Sang-ho Lee, the Koreans were only fixing one disc because it's very hard to move from one to another. It was never done in the world, had never been done before, and I did the first one. This was 18 and a half years ago. I went from one disc to another, so I could fix more than one disc at a time, okay? And that's what we do today. Now the process of moving from one disc to another, since I'm the first in the world to do it, you get to name it. You get to name it. Whenever you discover something in medicine, you get to name it, all right? So, being the first surgeon in the world to ever go from one disc to another, sliding along the front of the spine, this was, again, 19 years ago now that I did it. It's called the Duke Spine Slide. The slide. All right, we call it the Duke Spine Slide, and you're about to watch it. Okay? The Koreans had never done this. They only treated one disc, but most people have more than one disc, so I didn't want to make them come back and have 2 surgeries. I decided to just develop a technique that works to slide to the next one. So I always start at the bottom disc shot. Use the x-ray. You can see the tube is coming out of the disc shot. All right, the dilator stays there. This tube is now out shot. Okay, you see the tube is out. Show the tip of the tube. There's the tip of the tube. It's coming back all the way. You got to keep the dilator there. Shot. And I keep taking pictures called shots because I don't want anything to move. Shot. I got to keep that dilator in the disc, and I got to bring the tube all the way out. Now this is where you can really make a mistake. All right? You don't want to make a mistake. All right? So I'm being very careful. Now you can see we had no bleeding. We've literally lost 1 drop of blood the whole surgery. So this is also bloodless surgery. All right, I'm going to move up out of the disc, and I'm going to move north. Keep the head straight. You don't want the head rotated. Shot. All right, you see I'm almost out of the disc?
Yes,
and
we do.
I am now out. I could feel it. This part I created, the first in the world to do it. Now we've lost a little bit more blood. Not a big deal. Looks like 5 drops. That's because we're sliding along the ALL, anterior longitudinal ligament. Shot. Now, to slide properly, you have to stay in the middle. I need to check my AP view to make sure I'm still in the middle. Shot. I am. Look where the tip is. You see that? That's the middle of the spine.
Yes, we do.
Now I'm going to slide right along the retropharyngeal region to the next disc. Shot. This is the Duke Spine Slide. Shot. And one more shot. I should be on the disc. I am. AP. I want to check my front back. Make sure I haven't slid to the left or right, because that would be catastrophic if I tried going in. All right, we're still in the middle. I could go just a smidgen to the patient's right. Shot. Lateral view. Well, come on, let's not hit the table. Any questions?
Yes, we have a couple of questions. This next one
Shot.
coming from Hookem1963 on YouTube,
Shot.
asking, how do
AP.
I determine what my out-of-pocket expense will be?
The way you determine your out-of-pocket expense is to do your free MRI review. We're going to tell you what your out-of-pocket expense will be, and you pay it. You come get your surgery. We bill your insurance. If your insurance doesn't pay at all, worst case scenario, you don't owe any more money. It's our fault for not getting your insurance to pay. We don't blame you. On the other hand, if your insurance does pay your full bill, then we give you your deposit you made back, minus whatever your insurance tells us you owe. But remember, they have to pay the full bill. Okay, so shot. All right, we are at 2, 3, 4, 5, 6. There's no other way to know your out-of-pocket expense except to do an MRI review. Shot. We don't have like all of our pricing because it's not possible to do that. There's so many variables with patients. It would be very complicated. Shot. All right, perfect. There it is. You guys see the dye in the disc? And
Yes,
it's
we do.
leaking out. Let's get an AP. Shot. AP. AP is a front back, anterior posterior. Shot. All right. Wow, look at that. You got tears on both sides. Show us the tears, Jordan. One there and a really long one there. That's where the pain comes from. Lateral shot. All right. We are now at almost at the back of the herniation. A smidgen more. Looks good. Go. We're going to wait. Let me show the audience. The whole surgery, folks, look at this tube. You guys see this, Henry?
Yes, we
The
do.
whole surgery I do is inside this tube. It's literally 4 millimeters wide. That's why it's so minimally invasive. We have almost zero bleeding. There's no trauma to the tissues under the skin, unlike discectomy or fusion or artificial disc, where the surgeon is destroying everything down there and you don't even know about it because it's hidden from you. We don't hide anything. There's no destruction, and that's why our patients, shot, do not take narcotics. They do not take painkillers after surgery. Shot. All right, because we're not doing damage. The only reason your surgeon gives you painkillers like narcotics after your spine surgery is because that spine surgery he's doing or she's doing is destroying the inside of your body. And the way you know that is you feel the pain from the surgery after the surgery. And they give you painkillers. Well, the reason you're getting painkillers is because they're destroying your body and they're causing inflammation from the destruction of their surgery. All right, they don't tell you this, but that's the God's honest truth. They don't want you to know the pain you have after spine surgery is because they destroyed the normal structures of your spine, and those areas are bleeding and swelling and hurting. But with this surgery, we have no pain. They take no narcotics. They take a Tylenol. That's it. And usually the pain from the surgery is gone in a few hours because it's so gentle. All right, Henry, what videos have we not shown?
We have not shown what causes the second most common pain in the neck, which is the facets.
Let's do that.
Copy that.
Welcome back. So, Henry, now that we've shown the audience the second most common cause of neck pain, which is the facet joints, which, by the way, only account for 10% of neck pain as a primary cause of neck pain. The other 90% of neck pain as the primary cause is the disc injury. So when you have neck pain, there's a 90% chance it's coming from damaged discs. And they need to be fixed with the surgery you're watching right now, laser surgery at Duke Spine Institute. All right, Henry, let's show the audience how we fix facet pain while I'm cleaning up this herniation.
Copy that.
All right, welcome back. You can see how we deal with facetogenic pain. So why do we use the word genic, facetogenic, discogenic, sacroiliac joinogenic? The answer is genesis means the beginning or origin. And we use Latin words in medicine. Medicine, the practice of medicine is an old art, and the original artists that practiced medicine hundreds of years ago or thousands of years ago, they spoke Latin. So much of the terminology of medicine is Latin, okay? And Latin is an ancient language. Nobody really speaks it anymore, but actually my son, Arius, happens to be United States champion of Latin literature 2 years in high school, #1 in the entire United States. And he speaks Latin. He also speaks Korean now. He learned Korean at Princeton. He's actually learning Korean at Princeton. He's in his 2nd year, and he's pre-med. He's going to be hopefully a neurosurgeon, and the world will be very lucky if they get him as a neurosurgeon. He's going to be even better than his father. He's incredibly intelligent. Like, I look like a stupid fool compared to that kid. I don't know where he gets all his smarts from. It must be his mother. That said, we'll be very lucky if he takes over and does these surgeries when I'm gone. I don't mean gone on vacation. I mean gone in the great blue yonder. So I will operate till the day I die. I will probably be here in the operating room and have a heart attack or a blood clot or something. They'll probably have to code me. And Luis will have a lot of gray hair. And I'm sure a few tears will be shed. But then again, if I do things right, I'll pass the torch and somebody else will take over. Somebody who can do a good job and cares about the patients the way I do. I believe my son and daughter could both do that. My daughter wants to go to med school too. We'll see. She's getting A's. She's doing really good. All right. That said, yeah,
We have a couple questions.
I'll take them.
These next 2 questions are both coming from Steve on YouTube.
Hello, Steve. Welcome.
First question they asked is, when you are doing this procedure, are you cleaning up the extruded material on the outside of the disc, the inside surface of the herniation within the annulus, or both?
Both, Steve, both. So great question, Steve. You are correct. We are literally going inside the herniation and attacking it from the inside and zapping away the herniation, like layer at a time, till we get to the outermost surface. Does that make sense? Yeah. So you are correct. So we're getting not just the part of the herniation stuck in the tear, which is the important part that causes neck pain, but we're also getting the part that sticks out, that pinches on the nerves, and causes like arm pain, numbness, tingling, and weakness. So we're getting both. What's called the interposed herniation and the extruded part of the herniation, the part that's outside. Look at that piece right there. That's a piece of herniation. It almost has a waxy, like a blue candle appearance because it's got scar tissue in the herniation. The body has been attacking it with the inflammatory system, trying to get rid of it, but unsuccessful because your body cannot. There's another piece. Look at all those pieces of herniation coming out. Those are literally pushing on his nerves. That is the extruded herniation, Steve, right there. I literally just got rid of it, right? But there's probably more pieces, so that's not going to be all of it. That's going to be whatever percentage of it happens to be. I don't know how much it happens to be. It's impossible for me to say because I can't see the epidural space right now. But that's going to be a big part of it right there. You just saw the extruded part of the herniation come back into the disc and we took it out. Now, we have a name for that. And, you know, since I pioneered this technology, I get to name a lot of things because I'm the first person to see a lot of things in the world, since I'm one of the first in the world to do this. There's another. We call this a reverse herniation. So that piece of disc material I'm zapping right now used to be inside the tube area, but it shot out in the tear. Ah, come on. These pieces of disc just drive me crazy. I waste my time. Little pieces. They all want attention. Take me out. Take me out. You're small. Take me out. I will block you. There's a big piece of herniation right there. I will block your view until you're forced to deal with me. It's like a really bad girlfriend. Right? Or ex-wife, which I don't have, by the way. All right, keep the questions coming, Henry. I'm starting to digress. Let me
No
show.
worries.
There's another piece of herniation right there. Okay? Again, the herniation we call the herniated disc is made up of about 25 of those on average. You know, some people 20, some people 18, whatever. But the average is around 25. It's not always 25. Some people it's 40. But there's probably a bell-shaped curve as to a distribution, a mean distribution of the number of herniations. All right, we're almost done. So get your questions in. I can answer questions face-to-face. The next surgery we're doing will be in OR2, which does not have a camera. It's going to be another Duke plasma rhizotomy, so you guys won't see that one. But we're going to be back in about 45 minutes to an hour with our next surgery in room 3, which is our broadcast room. It's operating room 3, and that will be a Duke laser disc repair lumbar, right? How many levels? 1 or 2? 1? Just 1. There's another herniation right there with an SI joint. All right. So what do we got? A single level DLDR and then a DLDR with an SI? All right. All right. Hopefully you're learning the truth watching our channel. I don't tell lies. I don't make shit up. I don't need to. I'm not perfect. I can't be perfect. I don't want to be perfect. Don't expect to be perfect, but I accept the fact I'm not. Whereas other doctors never want to admit they don't know stuff. I don't mind admitting I don't know stuff. I don't have an ego, but we do tell you the truth. I want people to know the truth. Truth is more important than anything else to me. When you know the truth, you can make decisions that you can have expected results. Let's put it that way, right? So you can make choices that are based in truth and fact rather than bullshit. And that's important. As a doctor, you have an obligation to help your patients know the truth so they can make choices, right? Like it would be wrong for the doctor to tell a patient that they don't have cancer when they do. And they just don't want the patient to know the truth because they don't want to hurt their feelings or whatever. But patients need to know the truth. I mean, sometimes the truth sucks. But at least if you know the truth, you can make good decisions for yourself. Doctors should not be making those decisions. Patients should. The doctor's job is to educate, inform, diagnose, and then provide treatment when it's appropriate. And I believe people need to know the truth about their back and neck pain. All right, we're just about done. I got about 2 minutes left, I think, unless something pops up out of nowhere. I'm going to answer your questions face to face so that you guys can see me and we can have a nice conversation and I can drink some coffee. Oh, wow, look at that piece right there. You guys see that herniation that just popped around the corner? Damn,
Yes, we do.
too big to fit. I got to grab it and pull it. All right, almost done here. By the way, we've lost about, I don't know, maybe 20 drops of blood. We had a little bit coming out when I switched levels, but for the most part, that's it, guys. 20 drops of blood is called 1 milliliter or 1 cc, and a milliliter of blood loss for spine surgery is unheard of in any other type of spine surgery except this one. Duke laser disc repair, virtually bloodless surgery. Let's go.
How much time we have?
I mean, minutes here. You know, I don't know what to tell you. I mean, they keep getting these stupid little pieces of herniation. You know, these are garbage. They're not even a real herniation, you know. It's just calcified end plate cartilage. It doesn't do anything but get in my way. Come on. And they're dense. These things are dense because they're calcified, so they have weight, and they just want to sink back down to the bottom and block my view. All right, questions?
Next question from Steve, once more on YouTube, asking, it looks like the guide wire is entering the nucleus and then being slowly retracted and cleaning up along the way. Is that correct?
No, there's no guide wire right now. This is a tube. The guide wire is gone. The guide wire was used just for a few seconds. So the first thing I did was I placed the needle, and then I placed the guide wire down the needle. That was on the first disc. And then once we did the first disc, we moved the tube, it's called the dilator, we moved it to the second disc. And now we're repairing the second disc. Yeah, so there's a sequence with needles, there's another herniation. Needles, guide wire, dilator, tube. And then going to the second disc, it's, you see that piece of herniation right there? Damn. Little baby abominable snowman. Little abomination. There it is. Good riddance. It's like that guy that just won't leave you alone at the parties. Right? Nikki's laughing. She's like, yeah, I know a lot of those guys. Right, Nikki?
We have another question
Sure.
coming from Lanu on YouTube.
Oh, Lanu, welcome. I was wondering where Lanu was.
I know, right? Glad to have you as always. Asking, can neck pain be measured, for example, like level 1 pain, level 2 pain, and so on and so forth?
Yes, neck pain can be measured. And typically we use called the visual analog scale, VAS. And it's scaled 1 to 10 or 1 to 100, your choice. To me, I don't really care. Huh? Give us another minute. Just these little pieces of herniation are getting in my way. Is it really low? Yeah, then go ahead, spike it. If you ever watch Star Wars, anybody watch Star Wars?
Oh, of course.
These are minox. These little pieces of herniation. Remember the minox?
I do, of course.
Okay. These little things that just get in the way and bite on your cables and just frustrate you, even though they won't actually shut your ship down. They can, but you just got to deal with them. Little minox. All right. Sorry, go ahead. What question do you have?
No current questions, so we do have a comment coming from Betty on YouTube.
Yeah, Betty, sure.
Saying that they had a Zoom call last October. Doctors told to put screws in her back. Grade 1, the best words I heard from you. Whoa. So I never missed one of your surgeries. Thank you. I've learned so much from you. Keep up the good work. I am so glad I found you on the web. I'm grateful.
Oh, thank you so much. We're grateful for you as well. Yeah, I was saying earlier to Lanu about, did you change it? I was telling Lanu earlier, I don't really care about grading pain for a patient. What I care about is if the patient wants to get rid of their pain. It doesn't matter if you call it a 1, a 3, a 10. If the patient doesn't want that pain, they should be able to get rid of it with their treatment, okay? That's what I care about, eliminating pain. Whether you want to call it a 1, a 5, a 10, doesn't matter. What matters is, do they want to get rid of their pain? That's all that matters. There is no threshold for fixing pain. I don't wait until a patient has a 10. I let the patient decide if they want to be fixed or not. It's not my choice. I'm not the one living with pain. They are. So if the patient wants to get rid of the pain and it's a 1, then we'll get rid of it. If the patient says, you know, I can live with my pain, I'm fine, then they live with it. That's their choice. What I do is I make sure they understand they have a choice. It's not my job to tell somebody to fix their pain. It's my job to fix it if they want it fixed. All right, that's about it. I don't see anything more. I'm at the fibers of the PLL. I don't see any more herniation. I'm pretty happy. That's a bit of a bone spur right there. Kind of a calcified thing. Not much we can do about that. It's calcified ligament. But let me just pull back. Just verify. I don't see anything else. Nope. Looks good. I think he's going to be happy.
Lights on, please. Thank you.
All right. Great job, team. Scope use is a 7.
No current questions, so we do have a comment coming from a user on LinkedIn saying, Merry Christmas, Dr. Duke.
Merry Christmas to you. Thank you so much. We'll be back, folks, in 45 minutes with another surgery. I want to show you the incision. Okay. It's tiny. 4 millimeters. We lost about a milliliter, 1 ml of blood, which is less than you lose on a nosebleed. Can we have some light here? Okay. I'm going to hold pressure for a minute, and you guys can see the tape measure.
Yes,
right?
we can.
You got inches here and centimeters. All right, here we go. You guys see the incision?
Yes, we do.
Literally 5 millimeters. That's it. We're going to put a little dressing on that, and the patient's going to go to recovery, spend an hour, and go home. And he'll come in for a quick checkup in the morning with his family, and he can fly home tomorrow afternoon or drive home. Thanks, everybody. Good work. Good job, everyone. Thank you. Thanks for joining us. We'll be back in 45 minutes.